We're going to talk about fixed and removable dental prosthesis for this lesson here, this set of PowerPoints. These are the objectives. You can read through those on your own. So most people don't think about the importance of teeth and how it affects so many aspects of our lives. Obviously, we use teeth to break down food while we're chewing, but it also helps with a lot of facial support and structure, speech formation, and of course, aesthetics. I think there's several of these images online that kind of show beautiful Hollywood people without teeth, and it certainly changes the way they look. Dental hygienists must be knowledgeable about how to meet the specialized needs of a patient with a prosthesis. And this could be lots of different prostheses, not just full dentures, but especially if it's a large partial or a full denture, we have to understand how to care for that and how to care for our patients' oral health who have those appliances. So the terminology, we have edentulous, which is derived from the Latin word edentus, meaning being without teeth or lacking teeth. And then we have prosthesis, a fixed or removable appliance that is designed to functionally and cosmetically replace a missing natural tooth or teeth. And we have about 5% of adult American population are edentulous. And this is much less than it used to be. It used to be far more common for individuals to lose their teeth as they aged, either through caries that ended up in tooth loss or periodontal disease, or a combination of both. There was sort of a thought that as you aged, you just simply lost your teeth, and that was just sort of part of aging. So that has definitely reduced with modern dentistry and better oral hygiene care and better professional care too, regular cleanings and education and so forth. So risk factors for tooth loss, obviously dental caries, periodontal disease, low socioeconomic status, inadequate access to professional oral care, low frequency of professional care, dental hygiene cleanings, so forth, and then poor daily oral hygiene. Prior to 35 years, so 35 years or younger, typically caries is a major factor of tooth loss. And after 35 years and older, it tends to shift more to periodontal disease, playing a bigger role in tooth loss than caries. So issues experienced with tooth loss. Humans' responses associated with tooth loss include the 5 stages of bereavement, behavioral changes, embarrassment, and loss of dignity. These responses must be considered when providing care for edentulous or partially edentulous patients. So you can think of those psychological, behavioral, effects, behavioral changes, embarrassment, loss of dignity. You might have a patient who feels very uncomfortable removing their denture in front of you. And we need to look at the tissue underneath their denture, but it can be very challenging for somebody to want to be seen without their denture. So we have to be really empathetic and sensitive to that. And then we have the physiological changes like the residual ridge and alveolar bone resorption. Older adults resorb bone faster than younger people. I have had patients who had full dentures in their teens and they still had some ridge, in their 70s. So that, everybody kind of resorbs at a different rate, but generally bony changes are observed greater in the mandible, and more significantly from those in the maxilla. So when we do see ridge resorption, typically we see it to a greater extent in the mandible. And the resorption rate is 4 times greater in the mandible than the maxilla. So that's important for you guys to remember for a quiz or exam. And it just depends on the person and their circumstances. But as a general rule, if there's nothing in the bone anymore, it tends to resorb. So that's why we lose that ridge after extractions. And then it's kind of like a muscle that you don't use, it atrophies. So it's a similar thing that happens with the bone, but it depends on the person. And we see it happen faster in the mandible than in the maxilla. So issues experienced with tooth loss, we talked about the physiological problems from resorption, and a little more detail on this. This can include discomfort related to the proximity to the mandibular canal. So if this bone starts thinning out closer to the nerve that's running through the mandibular canal, there can be more discomfort associated with that. Paresthesia in the lower lip and chin related to exposure of the mental nerve. So you can see how bone resorption once it starts happening to a larger amount can really start to cause all other problems as these nerves can be exposed. Diminishes stability and retention of the prosthesis as the bony ridges continue to flatten with time. So they just don't have the same ability to retain or to have like a suction or some kind of retention of the prosthesis, the flatter and smaller the ridge gets. So they will rely more heavily on things like the glues and the different bonding materials that they use. You'll have a patient that they take it out for you, and maybe their whole ridge and the whole denture are covered in, like C-bond or one of these sort of tacky glue-like substances. And, that's obviously difficult to actually visualize the tissue when it's covered in this kind of glue. Irregular resorption can create numerous sharp spikes in their bone. So they could have little bony, sharp areas that can also become uncomfortable or rub against the denture. Difficult to fit with exostosis, palatal tori, mandibular tori, or large maxillary tuberosity. So all of those large bony protrusions can cause difficulty. Decreased stability, unbalanced occlusion, and TMJ disorders can all be associated with, full dentures, difficulty with different aspects of wearing the dentures. Obviously, they're not going to be able to chew as well. They're not the real fibrous foods that need to be chewed. If they have an unbalanced occlusion or TMJ or decreased stability, they're not going to be able to enjoy their food at all to the same degree as someone with natural teeth. Dissatisfaction with appearance, that can happen as well. They might not like the way it looks. Everything looks maybe too perfect, or maybe they feel like they're too big, or, various things like that. Individuals can have missing teeth replaced by dental implants, and you can review that some more in chapter 31. That was our last week's topic, or by fixed or removable dental prosthesis. This is a major change and needs time for the patient to adapt. It can take a good better part of the year for a patient to get used to dentures. And at first, very oftentimes they regret what's happening, and they don't like the way it. Many patients will say, sort of offhand, give me dentures, then I don't have to worry about my teeth. But really, they don't understand how natural teeth are so much better than a prosthesis any day of the week. And when they say that, they're just thinking of, fillings and getting my teeth scraped, and they're thinking of all these things. But the other side of that coin is so much worse. If that's what you have to have because of number of different reasons, then it's a wonderful option that we even have it available. But to wish that you would have dentures over natural teeth, oftentimes people just don't realize, they don't think about all those aspects that we were just talking about. And like the notes say here in the side, things like just eating the food, which is of course, but also tasting the food. It affects taste because the dentures are covering up some natural taste buds in the palatal area, especially. That's going to cover a big portion. And sometimes they can feel like the denture is so large that they're gagging on it. I've had patients say, I can't wear it, it makes me gag. or just feels weird in their mouth. So the partial denture is used to replace some teeth, but not all of the natural teeth. Partial dentures may be fixed or removable, and they could be fixed to dentures or retained by a denture. And then you can see here, there's also, as far as removable prosthesis, we can also have an obturator, which is used when somebody has, and we'll talk about that a little bit in our cleft palate, but an obturator is an appliance that's used to close a surgical site. If somebody's either had a cleft palate or they've had oral cancer and they've had a large amount of bone resected, they may need something to close like the palatal part of their mouth so that there's no communication between the sinuses and the oral cavity. So it can have a very strange shape because it's basically plugging a hole in the roof of the mouth or the palate. And then there are, let me see, where am I? A fixed partial denture is either cemented permanently to natural teeth or screwed to dental implants or abutments and is commonly called a bridge. And we've talked about that. You guys are familiar with that. And it cannot be removed by a patient. It's fixed. So here are some examples of removable dentures, just different pictures, different shape, different teeth involved. They can have metal clasp. They can be all acrylic. This is sort of the newer version, what they like to make. The metal is a little bit of the older version, but some people really like them, still prefer the metal for stability. Sometimes people feel that these are too soft and bendy. So it just can kind of depend on the prosthodontist or the dentist who's making it and the patient's desires. Complete set of denture, an overdenture for an implant. You can see the little buttons here where the implant snaps in. And then, like we talked about the different parts of the tooth, we have the abutments, and we learned about abutments on an implant, but these are the abutments on a bridge, and these can be a prepped tooth. So a natural tooth can be prepped with this shape to fit the crowns, and they call these the abutments. And then the pontic is the tooth in the middle that has no root with it. So pontic, artificial tooth or teeth that occupy the edentulous space and replace the missing tooth or teeth. So here's an image of an obturator and somebody who has a hole in their palate due to likely oral cancer is what I'm assuming that has to do with, because they're missing all these teeth on the side here as well. So this is an example of an obturator. So educating the patient is really important. We want to educate them on the expectations, what they can expect after their partial is made, cleansing, how to cleanse the prosthesis, so oral hygiene instruction, the use and the care of it, how to care for it and keep it in good shape, and then regular maintenance appointment. Even if they have full dentures, they still need to come in once a year to have their tissue examined and to have their prosthesis looked at as well. So we want to educate them on several aspects. One, eating. We want to talk to them about avoid repeated gum chewing or sticky foods and the use of anterior teeth for repetitive incisions. So if they're using their anterior teeth to sort of cut and mince food, then they're going to have a lot more wear. Or if there's just not as much occlusion on the posterior teeth, whatever they are, if they're prosthesis or not, and it's just wearing heavier on the anterior, they're going to wear their anterior teeth down very quickly because they're just not made for that kind of wear. Consume food in smaller pieces. So kind of educating them on how to transfer maybe the style of food that they've been used to eating, eating slower, taking smaller bites, lengthen the chewing time, and then evenly distribute the food throughout their mouth so that they don't have just one big chunk of food on one side, because that could sort of dislodge their denture and make it rock, or something that's really uncomfortable for them. Speech, practice reading aloud and speaking in front of a mirror. Many people don't realize that this is going to be something that they're going to have to think about. I've had patients that say, I'm embarrassed to talk because I feel like I have a lisp, or I feel like air is coming out of my mouth in a different way that it didn't used to come before. So they have to practice. Educate patients on what to expect as far as loss of facial height, the vertical dimension, reduced lip support, sunken maxillary appearance, and increased chin prominence. And this is going to happen at various rates, but especially within the first year of, especially something like full dentures is pretty much what we're talking about more. They're going to have some bone remodeling and some shape changes in their facial structure. And they'll get it back to some degree when their denture is in their mouth. It'll give them a fuller look, but when they take out their denture, everything will kind of look sunken and a little bit deflated. So education on expectations continue. The majority of the alveolar ridge resorption occurs in the first year. So that's when they're going to see the most changes. And they oftentimes have to come in for adjustments in 6 to 12 month marks. Bone resorption is greater in the mandible, 4 times greater in the mandible. The alveolar ridges continue to change or remodel. That's when bone changes throughout the life. And like I said, some people faster than others. New dentures or relines are needed roughly every 4 to 8 years. And that, of course, again, depends on the person. Dentures should be permanently marked with the wearer's identification, especially if they're a nursing home patient. There needs to be some kind of a permanent mark that identifies who it belongs to. Oral mucosal conditions usually caused by improper oral hygiene care, extended denture wear, or poor prosthetic fit, so a poor fitting denture. So factors affecting oral mucosa of denture-wearing individuals. So we have systemic diseases and conditions under that. So with systemic conditions, diabetes, anemia, menopause, malnutrition, nutrient malabsorption in digestive tract can predispose to Candida albicans. So basically, if they're systemically not healthy, or if they have vitamin deficiency, micronutrient deficiency, that's just going to increase their susceptibility to getting sick. Their immune system's not going to be as strong. And so they're going to be more, plus with this appliance in their mouth, they're constantly going to build up more bacteria and possibly yeast, predisposing them to Candida albicans. So they need to be aware that that's a higher risk for patients who wear especially full dentures, is the Candida. So poor general health, salivary gland dysfunction, decreased tolerance to stress, impaired healing, emotional strain, medications, all of these factors can affect the oral mucosa of denture wearing individuals. So we have to just be aware that they're at higher risk for general poor health. Xerostomia is another big factor that can affect their oral health. We want them to understand about the role of saliva with a denture. If a mouth is dry, that denture is going to be far more uncomfortable, and it's not going to be retained as easily. Of course, we think of saliva in its role for lubricating our tissues, for keeping the tissues healthy, for mineralizing teeth. But it also has an adhesive action, and again, a lubrication and cushioning effect for denture wearers. So dry mouth can cause these frictional irritations. We can have sores in the patient's mouth if they have dry mouth and wear a denture, altered taste perception, cracked lips, fissured tongue, and then burning mouth syndrome. All of these can happen if somebody, especially if they're a denture wearer and they have dry mouth. So more about dry mouth or xerostomia. We want to be aware of patients who have the Sjogren's syndrome. They're going to be, of course, at higher risk. Those who suffer from behavioral health issues or emotional or anxiety state mental health, various mental health issues. If they don't drink enough fluids, they have a negative fluid balance, selected nutritional and hormonal deficiencies, patients with AIDS, if they're anemic, polyuric states, that's involving usually something in their renals, like a kidney condition, drugs or medications, and then therapeutic radiation if they have had radiation. All of these situations can induce xerostomia. And we know that as people get older, they're at higher risk for more systemic conditions, and also they may at the same time have to wear a prosthesis. So the notes here says, although the exact cause of xerostomia may be difficult to identify, the most common factors associated with xerostomia are these those ones that I just laid out. So now we'll kind of go over the classification of the different lesions that are more common to be seen in patients who wear a prosthesis or a denture. There's a reactive or a traumatic lesion, and this is caused from an ill-fitting denture prosthesis from the friction and the rubbing. And an example of that would be ulcers and sores. There's also the focal or frictional hyperkeratosis, and that adds sort of a extra fold of tissue. And then there's the denture-induced fibrous hypoplasia, or the Epilis fissuratum. That is that very classic, it usually happens up in the vestibule, and it's when the top ridge of the denture is rubbing up in the vestibule, and that creates a fibrous hyperplasia, and there's a picture of that. So here's in the descriptions for each one. We have for the ulcer, red, inflamed, ulcerated appearance underneath or at the margin of the denture. Focal frictional hyperkeratosis, hyperkeratinized white lesions usually resolve with time of discontinuation of underlying trauma. So these tend to, all of these really would resolve. Palpate to see if, I guess these are not sorry, I thought that these were specifically related to each one, but I think these are just some things to be aware of for the various pathologies that might be seen in the mouth. So palpate to see if it freely moves. We always do that. Is something bound down? Can you wipe it off? If it's elongated, single or multifolds or fibric tissues at the denture border caused by long-term irritation from an ill-fitting denture, that's your Epilis fissuratum, is these fibrotic tissue folds. And like I said, there'll be a picture here in just a second. Infectious lesions, chronic candiditis, other possibilities for dentures, for denture stomatitis includes poor oral hygiene care, continuous wear of prosthesis that's ill-fitting, systemic factors, and I feel like we're missing end chemical. I feel like that got cut off. Maybe just end chemical. I'm not sure. So denture stomatitis, angular cheilitis, generalized redness of the mucosa, velvet-like appearance, pain and burning sensation, typically under the maxillary denture. So you'll see sort of just a generalized redness under the maxillary. Angular cheilitis we'll see more in the corners of the mouth. It looks eroded, encrusted on the sides of in the commissures of the mouth, and then moderate pain. It's uncomfortable, might crack and bleed. So here's some examples of denture sores. These are kind of blurry, but you can see the sore and you can see what it looks like with the denture in there, and just some really red spots in a few areas here and here. Here's the Epilis fissuratum. It's like a fold. And then here again, here's another fold. So these are just fold. And it's because this part of the denture is rubbing, just rubbing, and it gets the tissue to create a fibrous hyperplastic fold of tissue. Here's an example of the denture stomatitis. You can see how very red it is and how it's very demarcated. And there also looks like there's some kind of fibrous tissue here. And then again, you can see it on this one too. See how it really is bright, bright red all around. And then here's where the denture doesn't sit. So it just sits around here. So all that's denture stomatitis. Candidus, it can be that lacy white. It can just be very red. It looks like there's a little bit of bumpiness there too. So that can be and then the angular cheilitis is just that red cracked in the corners of the mouth. Here's a mixed lesion. So we have papillary hyperplasia. You can see how red it is, but also there's all of this like little tiny dots all over the palate, and it's very, very red, little circular raised tissue all over the palate. So that's a mixed lesion, papillary hyperplasia. Then we have these extra kind of keratinized folds of tissue along the ridge. Prosthesis induced fibrous hyperplasia. So again, similar to the epilotus fissuratum, just in a different area. Chronic denture-induced trauma or irritation has resulted in an overgrowth of soft tissue. The chief complaint from the patient was an ill-fitting denture. So that's mostly what causes this hyperplastic tissue. Here's another mixed reactive. We have a reaction to like an ill-fitting denture and then an infectious lesion. Palatal papillary hypoplasia, got the same thing going on, and it has some candidiasis. So these could be similar as well. They could have candida and be that papillary hyperplasia. Overgrown, oops, I missed that one. Note that the generalized granular, so that's kind of that's what it has, this kind of granular look to it. Erythematous change of the palatal mucosa matches the shape of the repeatedly relined removable partial. So you can see the outline of the partial. And so that's how you know maybe it's ill-fitting, but maybe they never take it out. They're like living with it in their mouth always. And that patients need to take their dentures out so their tissue can breathe. Also note denture-induced papillary hyperplasia on the palate. I think we already pointed that out. So here's some patient education tips caring for the removable dental prosthesis. Explain the types of chemical cleansing agents, frequency and duration of their application, and other instructions for their use. This table in the textbook is really good, very, very thorough. It's too much to put on slides, but I'd encourage you to read through those tables. Demonstrate the technique for mechanical cleansing of the prosthesis and cleansing and massaging of the oral tissue. They want to wipe down their tissue. They want to massage it. They can brush their tissue with a very soft brush or wipe it with a washcloth, but it needs to be cleansed. Provide special instruction for gentle cleansing of soft lining material if necessary. So if had a soft reline, then they have to be very careful, or else they'll just can take out that soft reline material. Reinforce the need for regular professional care for denture wearing individuals, which includes annual intraoral and extraoral assessment, examination of the prosthesis. So doctor needs to look at the prosthesis, look at the tissue, make sure that it's fitting well. And they also should actually have a pano every few years, even if they have no teeth, to make sure that the bone and everything, there's nothing happening in the bone or in their joints or different things like that, to make sure everything's healthy. Explain the potential harmful effects of improper prosthesis care and oral hygiene neglect. Emphasize self-care strategies, including daily oral hygiene care, adequate nutrition, oral tissue self-examinations for oral cancer, and resting denture-bearing surfaces. So anywhere that's constantly in contact with the denture, they have to understand that that needs attention, or else it's not healthy for the tissue. Recommend techniques and products for denture use, care, and cleansing. Avoid oxygenating and hypochlorite type denture cleaners in the presence of a liner. Those just tend to be a little bit too harsh, and it could wash away or damage the reline. Tissue conditioners and implant nylon attachments. So the little gaskets, I call them little rubber gaskets. Anything that's too much of a harsh cleanser can damage those parts. Daily oral and denture hygiene care. Advise against denture home repair kits. Encourage for them to have a professionally relined at a dentist. Discourage denture adhesive with a stable and retentive prosthesis if needed, just 3 to 4 pea-sized drops. So sometimes they will just load that thing full of Fix-It-In or Polygrip or Seafoam. But if they have to put that much in their denture, then something's wrong and needs to be something needs to be done at the dentist, or maybe they even need a new denture. If they do need a tiny bit, like a few small pea-sized drops, that's one thing, but they shouldn't need, a massive amount of adhesive material. Encourage self-examination for proper fit, deposits, calculus deposits or stain that does build up on dentures, and abrasion. Remove at night to allow tissue to rest. Very important that many people don't realize how important this is. That's a huge thing with the irritated tissue or the candidiasis. Patients could still get it even if they take it out at night. They could still be susceptible to those things, but somebody who never removes their denture is higher risk. Brush denture, or at least rinse after each meal and before bed. Rinse saliva and loose debris and any denture adhesive material. Dilute, basically bleach, 1 teaspoon of bleach, 1 teaspoon of detergent to 4 ounces of water, and soak it for 5 to 10 minutes. Alkaline peroxide, many denture cleaning, there's lots of different denture cleaning products, and they can soak for 15 minutes or overnight. Rinse well, and always change the solution every day. Brushing denture or partial, rinse saliva, loose debris, any denture adhesive material. Firmly grasp the denture in the palm of the hand and brush with mild soap solution or non-abrasive soap. So you want to hold the denture in such a way that if you're cleansing it, you want to put some towels in the bottom of the sink, and you want to hold it in such a way that it's not going to slip out. And usually we hold it from top to bottom. We don't necessarily palm it, because it could kind of, if it's a partial, we could bend it. Or if it's a full upper denture, it could sort of slip out of our grasp. So usually we want to hold it more kind of top to bottom when we're brushing it. Discourage use of abrasive denture powders and pastes, and rinse completely. Inspect for debris or any leftover cleanser, and then place the denture in a denture cup. They need to cleanse their oral mucosa on a daily basis. Rinse mouth with warm water, antimicrobial mouth rinse, or saline solution, soft toothbrush or soft cloth, like a washcloth, and long strokes posterior to anterior to stimulate and massage and cleanse their ridge. Brush or scrape the tongue, very, very important. And then stimulate the tissue with their thumb and index finger. They can massage the ridge, the edentulous tissue, by applying pressure and then releasing. So just massaging the whole ridge, and you can demonstrate that on them by sort of just rubbing your thumb and your index finger along the ridge and sort of gently massaging it and pinching it. For annual continual care, it's important soft tissue examination for early identification of cancer or other oral conditions, cleansing and maintenance of the denture. We want to make sure that they're good, they don't need adjustments or some kind of replacement or reline. Evaluation and reinforcement of good oral self-care, both for the denture and for their mucosa. Professional care of full and partial dentures. The goal is to remove the plaque and the calculus and the stain without changing the acrylic or the metal. So I have taken a scaler and an ultrasonic to a denture before. I've done it many, many times, and you just do it very mindfully. Don't use the tip, don't gouge it. You don't want to gouge or poke at the acrylic or scratch up the metal and make it rough. Use a very light touch, and usually what's built up on there comes off very quickly. Special care is needed to prevent abrasion or wear on acrylic surfaces and to avoid bending or breaking the partial clasp, those metal clasps, or the retainer wires. So professional care procedure, update health history, client's personal history, the dental history, ask patients to explain or any complaints with their prosthesis if there's any problems there. We do our EO-IO, check their TMJ, visually inspect for cleanliness of the palate, prosthesis bearing mucosa, so the areas that come in contact with the prosthesis. Assess structure and form of alveolar ridge. Have they lost support, or are they losing retention support? Assess stability during normal oral function. So have them bite down on their denture and see how it's, is it rocking? Are they biting, in a good manner where they can actually like masticate the food, and then assess their oral hygiene status. I don't know. Actually, I haven't updated this. Is probably not page 75, but our professional care procedure is in the clinic manual. I know they've updated a few things, so this might have jumped a page in front or a page sometimes pages shift either up or down one when they add stuff to the clinic manual. So just you can do control find, and you can put in prosthesis care, and it should get you to the area. You should be able to find it, no problem. Biggest problem in private practice is cross-contamination. Use separate ultrasonic for patients' removable prosthesis. There should be a small ultrasonic. They're not that expensive in the grand scheme of things. That's only used for patient prosthesis. And of course, you double bag it, put the solution in one bag, and then put a second Ziploc bag, and then put that in the ultrasonic machine, let it run for 10 minutes, and then you'll rinse really good and give it a gentle scrub, make sure all the debris is off. And you just don't want to cross-contaminate. You don't want to put it in the bacteria soup that our other ultrasonic machines are. And that is all for prosthesis lesson. Okay, thank you.